witnessed something very phenomenal over the last 6 months. There has been a real surge in new evidence touching many of the recommendations that are in our secondary prevention guidelines. And we've just been kind of chasing and keeping up with those. Even since we finished kind of the original draft, we've had to go back and relook at things based on this evidence. And it's been a long time since I've seen this much evidence come out this fast, all on these particular topics. So it's very exciting that there's so much new to learn, and we appreciate you being with us today to try to learn some of that. As Elizabeth said, we will release this webinar guideline at the end, the webinar taping at the end of November. Our guidelines that you're going to see today are currently in publication. They've been accepted by the International Journal of Stroke, and the webinar will be released simultaneous to the publication of the guidelines themselves. So please watch for those and announcements about the guidelines being released. We're expecting 3 to 4 weeks from now. So I'd like to, at this point, thank you all, because we've had a lot of input on this particular guideline over the last several months. So we appreciate everybody who's spoken up and offered their input, and we've done our best to consider as much of it as possible. I'd like to introduce you to our fearless leader through all these months of change and all the new evidence. So the prevention module is co-chaired by Dr. Ted Wein and Dr. David Gladstone. We have the pleasure of having Dr. Wein with us today to talk about some of this new evidence and help us make sense of it. So Dr. Wein is a neurologist, and he's a member of the Department of Neurology and Neurosurgery at Montreal General and St. Mary's Hospitals. His specialty area is stroke prevention, and especially post-stroke spasticity as well. He's one of our international experts on that topic. And he's a fellow of the American Stroke Association as well. Ted's internationally known as travels always all over the world speaking on stroke prevention, and we're very fortunate to have him today. So thank you very much, Ted, and over to you.
Patty, thank you for that very kind introduction. I welcome all of you to share with me these new hot topics in secondary stroke prevention, which, as Patty has said, has just come out in the last several months, and we've had a flurry of activity. I'd like to thank my co-chair, David Gladstone, as well as the rest of the committee for helping put these guidelines into perspective and making sense. I'd also like to take this opportunity to thank all of you for participating in this webcam. Stroke is a personal subject to me. 3 of my 4 grandparents had strokes some 30 years ago, and it's amazing to see the progress we've made in stroke research, but each and every one of you involved in any aspect of stroke care really contributes to improving patient care and their quality of life. So I thank you on behalf of all stroke family survivors on what everyone on this conference does. I've included my email on this slide, and please feel free to use it at any time. Should you ever have questions that you would like to be answered, it would be my pleasure. These are my conflicts of interest, just so that you're aware. So our today's learning objectives, I'd like to review them. I usually don't, but I think it's important to know what we're going to be talking about today. And what I'm going to try to do is present the new guidelines that we've put out, and then review the data that's come out in the last year to help support why these decisions were made. So we're going to be discussing lipid management as well as diabetes management, and to find out the importance of controlling these 2 very modifiable risk factors, and with many treatments out there on how they affect stroke care. I think the biggest change in our guidelines is going to be the new treatment for patent foramen ovale closure and what the new trials have shown. And then a new area or new way of looking at patients is the comorbid patient, the patient with multiple vascular beds affected. Will we be opening up a new treatment paradigm for these patients as time goes on with new data, such as the COMPASS trial, which I'll be presenting to you very shortly. So I'm going to start off with our stroke best practice recommendations on lipid control and lipid assessment. So this is section 4.0. And the big question is, in treatment with statins, and we should always have baseline lifestyle modifications for modifying lipid levels. However, in terms of a medication approach, our current guidelines now say that secondary stroke prevention, that individuals should have LDLs of less than 2 millimoles per liter, or have at least a 50% reduction in LDL cholesterol. More interestingly is this new point, and I'm going to review all the data for this in a second, is for individuals with concomitant coronary disease. So starting to think of that comorbid polyvascular patient, we're recommending that LDLs be less than 1.8, or again, a 50% reduction in their LDLs, and we're giving that evidence of level A. And I'd like to go back now a little bit and review some of the data and some of the controversies that we've had in reviewing the lipid literature, and to give you a better historic understanding of how we arrived at these two suggestions. First thing is cholesterol, an absolute independent risk factor for stroke. And if you look at this meta-analysis published in 1995, we've had a really hard time when looking at total cholesterol level and subsequent risk of stroke. And if you can see in the 20 trials I've presented before you, you can see here on the bottom that there's really no strong correlation between cholesterol level and subsequent risk of stroke. If we go to this next trial, where we're looking at drugs, or the non-statin drugs, so the non-lipitors and the non-prestors of the world, how they decrease stroke rate, we can see that there's no clear-cut signal in using non-statins that they actually reduce stroke risk. And in fact, if you look at these trials with clofibrate 1, 2, 3 over here, if anything, it looks like it increases stroke risk. So this has been a long-standing controversy as to how does cholesterol affect stroke risk. When the statins came out, we had much more potent ways of lowering cholesterol, and more importantly, lowering what we call the bad cholesterol, or the LDL cholesterol. And in these first 20 trials over here with primary prevention of stroke, we can clearly see that there's around a 20% benefit in individuals with concomitant heart disease in reducing the risk of stroke. But these are all cardiac patients, and they have other vascular beds affected. But if we try to look for individuals who only have stroke, and is it beneficial in secondary prevention, and this is the secondary prevention module I'm presenting to you, we really only have one strong study that showed that lowering LDL levels was effective in reducing stroke, and that was the Sparkle trial, which I'm going to review for you guys in a minute. We do have 3 other trials using statins, the heart protection trial, the lipid trial, and the CARE trial, all of which showed strong trends to preventing stroke, but did not reach statistical significance. However, if we do a meta-analysis of all of these trials, we clearly see we get an 18% relative risk reduction in lowering LDL levels to try to prevent stroke. If we look at the secondary prevention trials, we have around a 12% reduction. And if we look at only people who've had stroke, so pure secondary stroke prevention, in individuals who have no concomitant coronary artery disease, we still only have 1 trial positive, which is the Sparkle trial. And I'm going to take you through this trial so you get a better idea of why and who did better in those trials, and then look at 2 trials that have come out in the last year and a half, which are going to change the landscape of how we treat our patients. So this is the original data from the Sparkle trial. In the Sparkle trial, you had to have a stroke within the past 6 months with no history of any coronary artery disease, and you had to have an LDL of greater than 2.6, and you were randomized to either get 80 milligrams of Lipitor, and if you couldn't, or atorvastatin, and if you cannot tolerate it, you were placed on 40 milligrams, or you were placed on placebo. And patients were followed for up to 5 years, so we have very extensive follow-up on these people. When we look at the primary results in box A, looking at fatal or non-fatal stroke, we clearly see that individuals had a 16% relative risk reduction in their stroke risk. We had a significant benefit in fatal stroke as well by around 43%, as demonstrated in box B. And if you look at box C, non-fatal stroke just missed significance by just a little bit. Most importantly, if we included the diagnosis of TIA, we had a 23% relative risk reduction. So patients achieved a mean LDL of 1.9, so they started off at 2.6, and their mean LDL went down to at least 1.9 or lower. So let's look at who benefited most in the Sparkle trial and what was special about those responder groups. So the first thing that we noticed is that individuals where we were able to decrease the LDL by greater than 50% had the greatest advantage of having decreased stroke reduction. And you can see that in all the different columns of all stroke, fatal stroke, non-fatal stroke, or ischemic stroke, and that benefit ranged from around 30 to 40% if we were able to get LDLs less than 50%, which is why in our guideline we've said, hey, if we're going to treat these people, it seems that the biggest bang for your buck is when you can get that LDL decrease by at least 50%. Who else did better? Well, if we stratified them in not quartiles here, but in 3 different groups, we can see that individuals where we were able to get their LDLs less than 1.8 millimoles per liter also seem to have the best benefit, almost a 30% relative risk reduction in subsequent stroke events. So based on these last 2 slides, where we clearly see that LDL reduction of greater than 50% and keeping your LDLs of less than 2.0 really seem to be the biggest bang for your buck in terms of reducing subsequent stroke risk. We have several new trials, however, that have just come out, and this trial was presented a year ago. It's the Improve It trial. This study looked at individuals with concomitant coronary artery disease and may or may not have had a past history of stroke, who were randomized to get 40 milligrams of simvastatin or 40 milligrams of simvastatin, as well as ezetimibe, also known as Ezetrol, commercially. This study has just been published online. It is available online for review, but the full publication has not been published in full format yet. So this is an EPUB ahead of print. So again, late-breaking data from 5 weeks ago that you're viewing here. So interestingly, if you look in column B over here, we can see that the individuals treated with simvastatin alone, seen in blue, had a higher event rate than if you were treated with simvastatin and Ezetrol together. And in fact, you had around a 21% risk reduction in subsequent stroke. But this was no different than the old statin trials that we had seen in the past, where I told you that the coronary population seemed to respond really well. But the question is, what happens to the individuals for secondary stroke prevention? Again, the focus of this module. Before I go there, I'd like to point out in the ischemic stroke group that their mean LDLs started off at 2.46, and they were lowered with ezetimibe as well to LDLs of 1.29. So we're having much more effective therapies that are able to drive that LDL lower and lower. And in our opinion, I think it's the more effective therapies we have out there that enable us to lower LDL levels to levels not seen before, that have enabled us to correlate LDL reduction and reduction in stroke risk. So let's look at what happened to the secondary prevention group in the Improve It trial. If we look here at individuals with a prior history of stroke, we can see that individuals treated with simvastatin in blue and prior stroke with ezetimibe and simvastatin, we can see a significant change. We can see that there's a significant reduction in subsequent stroke risk. So for the first time, we're able to strongly show a 40% relative risk reduction in individuals on maximum simvastatin therapy and have ezetimibe added on in individuals with a prior history of stroke who've now had MI, and they've been almost at that 2.0 level, and we're able to lower them to 1.3, that we can benefit these people by giving them another 40% risk reduction in subsequent stroke if ezetimibe is added on to simvastatin. So some very good and very strong evidence in a very large trial, predominantly a coronary population trial. So we're looking at the comorbid patient, the patient with heart disease and stroke, but clearly able to demonstrate that adding on this combination of therapy gives you a 40% risk reduction in subsequent stroke is quite impressive and something that we have not seen before. And also point out, one reason may be because we're driving LDL levels to low levels that we have not been able to do before with prior therapies. There's another trial that came out called the Fourier Trial. This study is another very large trial of over 20,000 patients using a new drug called evolocumab, which is a monoclonal antibody, which is quite effective at decreasing the risk of stroke. The population included in this trial, again, is a comorbid population, individuals with heart disease, peripheral vascular disease, as well as a history of stroke. And in this study, people who were already on maximal statin therapy were randomized to receive evolocumab on top of their current statin therapy to see if it would decrease the combined endpoints of cardiovascular death, MI, or stroke, as well as another subgroup of cardiovascular death, MI, stroke, or rehospitalization or coronary revascularization. We have extremely impressive results. We have 60% reductions in LDL levels that were able to be obtained with this product. And in fact, people went from mean LDL of 2.4 all the way down to 0.8. Again, LDL levels we have never been able to achieve before with prior therapies. So they had a 1.45 millimole reduction in their LDL levels, and that translated to a 15% relative risk reduction in the primary endpoint of death, MI, stroke, coronary revascularization. And if we just look at cardiovascular death, MI, or stroke, it had a 20% relative risk reduction. So again, some strong evidence that individuals with polyvascular disease really benefit from these extremely low LDL levels. When we look at what happened in the stroke rates in this group, so if you have cardiovascular disease or polyvascular disease, and your LDL is lowered from 2.4 and lowered by all the way down to around 1.4, we see that you can get a 21% relative risk reduction in subsequent stroke events. To put this number into perspective, aspirin for secondary stroke prevention only carries a 13% relative risk reduction. So at least in the polyvascular patient, there's strong evidence that lowering LDL levels when they're above 2.0 continues to give the patient marked benefit. What was interesting, if you look at fatal and non-fatal stroke rates, we can see that in the first year, you had a 19% relative risk reduction, but when you followed the patient out to 3 years, you have continued improvement, and these two curves seem to diverge, showing that long-term therapy is really where you get the biggest bang for your buck, almost doubling the relative risk reduction that you will see in your patients. So patient compliance and commitment to this therapy is a long-term investment for these patients. If we look at individuals with a history of stroke, so I'm going to now look at people with a secondary prevention portion of this study. People who already had a history of stroke, did adding on evolocumab further reduce their risk of stroke. This data is not yet published. It was presented by Bob Giuliano at the European Stroke Congress. It is available on the TIMI48 website for download and publication. I'm told by Dr. Giuliano is supposed to be at the end of November, where also will be simultaneously occur at the same time, where he will be presenting at the American Heart Association cardiology meeting, where they're going to be looking at polyvascular beds as to which combination of vascular disease responded best. For this presentation right now, we're looking only at the stroke cohort. And if we look at the individuals with past history of stroke, they showed benefit similar to the other group of around 15% in decreasing the risk of cardiovascular death, MI, and stroke. But the big question is, if you had a prior stroke and were treated with evolocumab, did that further decrease your risk of stroke? And unfortunately, in the pure stroke population, they were not able to further demonstrate a significant reduction in subsequent stroke risk. Saying that, however, I need to point out, if you look here in the red box, that there were only 95 strokes in the evolocumab group and 105 strokes in the placebo group. In addition to this, they have a mixed stroke population. And when we think of stroke patients, such as having atrial fibrillation, carotid stenosis, or lacunar disease, we would not expect evolocumab to have significant effects on the etiologies of some of these strokes. So one of the shortcomings of the Fourier trial is that they did not look at stroke subtype to help further guide our management. So for now, the use of evolocumab is indicated in individuals with concomitant coronary artery disease, but for a pure secondary stroke prevention in isolation with no other vascular beds, we do not see any benefit using this product right now. There will be other studies coming out which will helpful and further risk stratifying which polyvascular patient would be most beneficial to receive this therapy. The next subject I'd like to address is diabetes. We've known this has been a risk factor for a number of years. If you present to the emergency room with an elevated blood sugar, you have twice the complication rates of your stroke, you have less chance of having recovery, greater chance of intracerebral hemorrhage. But let's look at long-term secondary stroke prevention. And there are two new things that have come out. One is individuals who are on the newer diabetic drugs, such as the SGLT2 inhibitors, have really been shown to be quite effective in decreasing the primary outcome that's used in most of the cardiac literature of MACE, or major cardiovascular events. In addition, another study came out in the last year from a neurologist, which was the IRIS trial, looking at pioglitazone after a stroke or transient ischemic attack. And it does show some benefit in reducing the risk of stroke and MI, but it's offset by complications of increased risk of fractures, bladder cancer, and edema. So this was more of a proof of concept design for should we be doing this. This was looking at diabetic patients, but individuals who are beginning to develop insulin resistance, so they're probably pre-diabetic. And it was also shown in the study that we would reduce the number of individuals who became diabetic. But let me show you some of the data to make it a little bit clearer for you so you can better follow what I'm saying. So this study was called the IRIS trial. It was published by Walter Kernan. It was actually conceptualized by Dr. Larry Brass, who unfortunately passed away in the first year of this trial, and was carried on by Walter Kernan at Yale. And it was published in the New England Journal of Medicine in 2016. And basically, they looked at individuals who had a history of stroke or TIA and were insulin resistant. So this is characterized by having a blood test that's called a HOMA-IR, and it's not commercially available. So it's more of a proof of concept because it's not a test we routinely do. But what it did do was that we were able to randomize almost 4,000 patients, and we were able to show a decrease in the subsequent primary event points of MI and stroke. And I'm going to show you another analysis that just came out last week, so that's as fresh as you can get here, to show you what they had. But what their conclusion was, and if you look at the bottom of the page here, is that people with insulin resistance had a decreased risk of MI as well as stroke when combined, but was offset by an increased risk of weight gain, edema, fractures, and bladder cancer, but did give you a lower risk of diabetes. So what did the trial show? Well, the trial's primary endpoint was looking at stroke or myocardial infarction, and you had almost a 25% relative risk reduction in subsequent events. So very good for primary prevention, but it seemed to be driven by the cardiac population in the trial. And if you look lower down at the stroke group over here, you can see an 18% non-significant benefit, but the biggest benefit was here in the diabetes group, where we clearly see a 52% reduction in developing diabetes. So a strong indication to use that, but there were the other side effects that somehow may counteract the balance or benefit of this trial. What I'd like to share with you right now is this article that was just published last week, October 30th. And this was another analysis of the same stroke group to find out, was there anybody in the stroke group that clearly benefited? One of the things they did differently with this is they used the new definition of TIA, which is what we call a tissue-based definition. So while you may have transient symptoms less than 24 hours, if you do an MRI on a number of people, you can see while clinically they may be a TIA, they actually had a stroke. And so in this pre-planned analysis, they didn't go back and do this. They planned this in the middle of the trial, since the definition changed in the middle of trial, to see if we look back to see if we take those TIA patients who actually had strokes, was there a benefit in reducing the risk of stroke? And the answer was there absolutely was. There was actually a 2.7% absolute difference in stroke of any type, which translates to a 25% reduction in stroke, and you need to treat 36 patients over 5 years to show this benefit. If we look at ischemic and non-fatal stroke, you can see that there's clear benefits of a good 2% absolute risk reduction in these groups here. We also see benefits in individuals with large vessel disease as well as lacunar strokes. So again, a lot of preliminary evidence in this proof of concept design with the drug, unfortunately, that we no longer use very much secondary to complications, that while we can decrease stroke and MI risk, we do run the risk of having increased weight gain, edema, fractures. with the benefit of decreasing the incidence of diabetes. So this is something that we should keep our eye on for the future, and may give us a lot, lead to a lot of new trials to help support this proof of concept, perhaps with a drug that gives us less complications. In addition to this, there's been a number of new drugs that are out there in the treatment of diabetes, and I'm just going to go over this briefly. We have the IRIS trial showing some benefit. This is a wonderful review on all the new drugs that are out there. And in a nutshell, and in the interest of time, we have new GLP-1 agonists as well as SGLT2 inhibitors. And for both of these studies, we have evidence that they decrease the primary endpoint of MACE, or major cardiovascular events. In the GLP studies, there's only the SUSTAIN-6 trial that shows benefit in absolute stroke reduction. It does show evidence in other macrovascular events for diabetics, but unfortunately not for stroke. And the same for the SGLT2 studies, which I'm not going to review. They also show a benefit in most cardiovascular events, but again, unfortunately not for stroke. So in individuals with concomitant coronary artery disease, there's an indication for these products to be used if they are diabetic. We need to wait and see where stroke is looked at as a primary outcome in a primary stroke population to really see its efficacy in secondary stroke prevention. So for prevention in individuals with concomitant coronary artery disease, utilization of these drugs are suggested. And this is just the primary outcome measure of the SUSTAIN-6 trial, which I'm going to skip in the interest of time. And I'd like to talk about, to me, which is the hottest and most controversial subject, is patent foramen ovale. For years, we thought patent foramen ovale was a risk factor for stroke. We had great data to support it. It also seemed to be increased with migraine. Some people suggested larger size, greater shunts, greater number of bubbles going from the right to the left side of the heart were all strong predictors for subsequent stroke. Unfortunately, 3 trials done showed absolutely no benefit to PFO closure, and we wondered what we had done wrong. 5 months ago, 3 trials were published, all of which showed benefit in reducing the subsequent risk of stroke. And what was unique about these trials was really their inclusion criteria, which I'm going to review for you in a second. But we've come out with these new guidelines, and they'll be the first published guidelines for PFO closure, which are as follows. One is that it's not a simple formula. I think it needs to be, people with PFO should be evaluated with individuals with a strong background in stroke and stroke prevention. We recommend what these trials did differently is they used individuals who are less than 60 years old and not likely to have any other comorbidities, which will explain the stroke. The strokes have to be non-lacunar strokes. So all these new studies, which I'll talk about, excluded these little baby strokes caused by hypertension and diabetes, but really looked at what we'd call the ESIS, or the embolic stroke population, to see if that was the cause. And if you had a TIA, they used positive neuroimaging to confirm that it was a stroke by cortical symptoms. Again, individuals need to be evaluated by physicians with stroke expertise, and a thorough investigation has to be done to exclude other etiologies. And in these studies, thrombophilic workups were done on all patients. So let me review the studies so that you can see how we've gone along and gotten to this conclusion. This is a wonderful review article by Alan Roper in Boston. And basically on the top here, we have the initial 3 trials, Closure, PC, and Respect, all of which were, at least for Closure and PC, were negative trials. They compared PFO closure to antiplatelet or warfarin therapy, or both, and they showed absolutely no benefit. Similar, in the PC trial, they also showed no benefit of antiplatelet therapy or anticoagulation and PFO closure. The Respect trial was a little controversial because one patient was put in the wrong group, and it made the study slightly positive, but it wasn't clear. But we were really left at that time with 2 negative trials and 1 weakly positive trial based on an error. So everybody went back to the books and started saying, let's try to choose the ideal population. People with cortically based strokes, most likely to be cardioembolic. Let's look at individuals with a negative hypercoagulable workup. Let's look at the young population who are more likely to have that as the only reason for their stroke. And in fact, we had the Gore Reduce and Close trial, which both came back positives with very significant p-values showing significant benefit for these people. Also on the RESPECT trial, they did an extended follow-up of their patients for some 6 years on average follow-up, and found that there was improvement in individuals who underwent PFO closure. And I'm just going to review these trials briefly to give you an idea of what the actual numbers are, as well as many of the questions that still remain. So the CLOSE trial, and all these articles were published on the same day in the New England Journal of Medicine. So the CLOSE trial looked at individuals aged 16 to 60 with a mean age of 43. Everybody had an incredibly detailed workup to ensure there was no other cause. And individuals were included in the trial if they had a patent foramen ovale, and ASA is not for aspirin, but it's for an atrial septal aneurysm, or they had what they defined as a large shunt. So that's the blood going from the right to the left side through this hole in the heart, which we still see in 25% of the population. They also had to have greater than 30 microbubbles. So when you do a transesophageal echo, we would shake up saline, inject it into a vein, and see how much of these bubbles that we just injected go from the venous side of the heart to the arterial side of the heart. And they followed up the patients for 5 years. And the results were quite impressive. They had 0 stroke recurrence in the PFO group, and they had 6% recurrence in the individuals who were treated with aspirin alone. And this gave a huge benefit, with number needed to treat to prevent 1 stroke at 5 years as being 20. There were complications, and around 6% of people did have complications. The most common one was paroxysmal atrial fibrillation, and this is something that we've seen in other trials where we put in closure devices. It's always transient, but we will still need to monitor what the recurrence rate of atrial fibrillation is long-term in these patients. If we look at the REDUCE trial, so the second positive study, again, they used a young population of 18 to 59, the mean age of 45, so almost identical. You had to have a PFO. One of their criteria was a right to left shunt, but they didn't have as stringent criteria for the large shunts in terms of the numbers of bubbles going from right to left. But they had 81% of their patients were what we call moderate shunts, and they only had 6 to 25 microbubbles, so significantly smaller than the large in the previous trial of greater than 30 microbubbles. They followed the patients only for 3.5 years, as opposed to the almost 6 years in the previous trial. And what did they find? They found that there was an incidence of stroke of around 1.4% in the closure group and around 5% in the antiplatelet group. So again, a significant reduction in this carefully selected population where we've excluded all other causes, and the number needed to treat was 28 to prevent 1 stroke at 2 years. So again, very impressive numbers to support this as a concrete risk factor in the appropriate population. They also had around 6 to 7% of individuals who developed paroxysmal atrial fibrillation, and serious adverse events only occurred in 1.5% of the population. So this was another 2 studies in a row, one after the other, using similar criteria, both showing efficacy for closure. The last study was the RESPECT trial, and this looked at the follow-up from initially weekly positive trial to see what happened if you followed the people for up to 6 years. And in fact, we showed that there was significant benefit when this prolonged follow-up was there. The numbers needed to treat in this more mixed population, but again, a young population, was 42, so almost double the other ones, but still showed benefit. But the biggest group that benefited were individuals where you clearly had a large shunt going from right to left, with aspirin treated as well. The last concept I'd like to review before we go to questions is this trial here, which is rivaroxaban with or without aspirin in stable cardiovascular disease. This study is referred to as the COMPASS trial and was headed through McMaster University. What this trial basically looked at some 28,000 patients who had stable coronary artery disease and may have had other vascular risk factors, and randomized them to a number of different therapies to seeing if using anticoagulation was beneficial in decreasing subsequent cardiovascular events. I'm going to bring you here just to look at the eligibility criteria because it's a little bit hard to follow to hear for the first time. So if you had a history of coronary artery disease, peripheral artery disease, or both, you could go into the trial. In people who were young, less than 65 years of age, they were required to have vascular disease and at least 2 other vascular beds, or have at least 2 additional risk factors. That could have been smoking, diabetes, kidney chronic kidney disease, heart failure, or non-lacunar. So again, getting away from those lacunar strokes, non-lacunar strokes greater than 1 month. And so they had this smorgasbord of people who were randomized at high risk for vascular events to see whether rivaroxaban 2.5 milligrams twice a day plus aspirin was better than rivaroxaban 5 milligrams twice a day without aspirin, or aspirin with a rivaroxaban placebo group. Again, they're just trying to treat all vascular disease in the study. It's not necessarily stroke specific. What they found was that the low-dose rivaroxaban and aspirin was the most effective therapy at decreasing the primary outcome measure of cardiovascular death, stroke, or MI to reduce the subsequent risk of stroke. And I think that's very, very impressive that we had a stronger combination of therapy. I would just like to point out that the dosage of rivaroxaban 5 and 2.5 are not commercially available. And again, this was a proof of concept design on what we should be thinking for the future. What was most interesting about this is if you look in the red box and the blue box where they interact, is that stroke was significantly reduced in this trial. So both the primary and secondary prevention group was reduced by almost 50%, 40 to 50%. But if you look at ischemic stroke, it's almost a 50% relative reduction that we were able to see. So that's the really, really good news. The bad news was that it came at the expense of an increased intracerebral hemorrhage rate that is clearly not seen here, but it also was at the expense of having more major bleeds. And in fact, if we look at the major bleed event rate here, you can see it's 1.7, so 70% higher with a significant p-value. So while we're able to decrease cardiovascular events, MI, or stroke with this combination of rivaroxaban 2.5 twice a day and aspirin, it comes at the expense of having increased bleeding. So another proof of concept of perhaps new therapies that we should be considering and entertaining down the road for treating our polyvascular or comorbid vascular patient. So now I have several questions here, and then you can answer them, and I'm just going to go through them one at a time. There's 3 questions, and then we'll open this up for questions. So which individuals showed the greatest risk reduction in stroke recurrence in the Sparkle trial? Was it individuals whose treatment LDLs were less than 2.0 millimoles, individuals who had a 50% reduction in LDL, or individuals, or choice C, individuals whose treatment with LDLs were less than 1.8 millimoles? A and C, or none of the above? If you think back, the biggest benefit was actually in the individuals who had LDLs of less than 1.8 millimoles, or individuals who had 50% reductions in LDLs. And I apologize, but this should say B and C, and that's my fault, would be the correct answer of which population showed the greatest benefit in subsequent stroke reduction. Question 2. In a patient with concomitant coronary artery disease or an acute coronary syndrome and a history of stroke who is already on maximal statin therapy and presents on 2 occasions with an LDL of 1.9 one visit and 2 millimoles the second visit, should this patient be further modified, or are they really at maximal LDL level? And so our choices are: this individual is maximally treated and will not benefit from additional LDL lowering. The Improve It trial showed no benefit in further reducing stroke risk when ezetimibe was added on to maximal statin therapy in stroke patients with no history of coronary artery disease. Sub-analysis of the Fourier Trial showed benefit of secondary stroke prevention, and this individual should receive evolocumab. And fourthly, the LDL for individuals with stroke and coronary artery disease should be targeted to LDLs of less than 1.8. The correct answer is D right now, based on the current data we have. For choice A, the guidelines suggest in individuals with coronary artery disease and stroke that their LDL should be less than 1.8. So this patient is fairly close to target, but both the Improve It trial showed that lowering LDLs even lower showed ongoing benefit. The Improve It trial over here showed benefit in the patients with acute coronary syndromes, not with no history of coronary disease. So that would be the wrong part of that analysis. And the sub-analysis of the Fourier trial did not show benefit in secondary stroke prevention for individuals presenting initially with a stroke. and we're waiting for the rest of that data to be released. So goal is D, which is reflective exactly of what our stroke guidelines are at the present time. Question 3, a 45-year-old diabetic male presents with a transient pure motor hemiparesis that lasted for 10 minutes. As part of his stroke investigation, he was found to have a large PFO with right to left shunt. His vascular imaging is unremarkable, and a Holter monitor shows no evidence of paroxysmal atrial fibrillation. So what is the proper treatment for this patient? This man should be sent for PFO closure based on the recent CLOSE, RESPECT, and REDUCE trials. This man should have his PFO closed only if a thrombophilia workup is negative. More information is required regarding the size of the PFO, the number of bubbles present on TE, and whether an atrial septal aneurysm is present, or this man is not a candidate for PFO. So think about this one, because it's a little bit tricky, and it really helps delineate what's different about the new guidelines and new PFO closure trials versus the old trials. So question 1 is, this man should be sent for PFO closure based on the recent trials. The answer is, he had a TIA. By definition, that TIA should be have cortical symptoms, of which he has pure motor symptoms, which are not, and has to or should have imaging to confirm it if possible. So he doesn't qualify for that because we don't have the imaging and we don't really have cortical symptoms here. Choice B, this man should have his PFO closed only if a thrombophilia workup is negative. Well, the thrombophilia workup was part of the workup, so we have no data if it was positive. However, we're still dealing with a lacunar stroke here, and that is why this person's PFO should not be closed. Choice C, more information regarding the size of the PFO, the number of bubbles present, and whether an atrial septal aneurysm is present, is very interesting. But again, these new trials have no standard approach to size or shunt, and that still remains very controversial, and further trials will have to further tease that out to see who the ideal closure patients are. And the choice D is probably the correct choice in my opinion, because this man would not have qualified for the CLOSE, RESPECT, or REDUCE trial because he presented with what sounds like a TIA that's not tissue confirmed based on imaging of the brain, and most importantly is the lacunar stroke based on a pure motor hemiparesis. I hope this has been helpful to you, and I thank you for your time, and I'm more than happy to address any questions you have. Thank you very much.
Thank you very much, Dr. Wein, for that amazing presentation and information, and for all your work on the guidelines. If anyone has any questions, please send them into the question box, and we can address them in the next 15 minutes or so, 10 to 15 minutes. We'll just give everyone a minute to type any questions that they may have. Should all patients with stroke of unknown cause have a PFO investigation?
So, excellent question. So, any individual with a stroke of unknown cause should have, and we've delineated this in the stroke guidelines, should have the basic workup for stroke. And again, stroke of unknown cause depends on what investigations that you've had. Part of the investigation for stroke of unknown cause is a transesophageal echocardiogram, which would detect a patent foramen ovale. It's important to note that individuals who are being investigated for this should be between the ages of, or less than the age of 60. It's probably the most important thing. So yes, absolutely, but please don't forget that Holter monitoring and a thrombophilic workup, so looking for hypercoagulable states, are also very important and part of the investigation protocol, as is CT angiography from the aortic arch to the circle of Willis to rule out other causes. And please don't forget other extraneous factors in stroke in the young, which does include birth control pill, as well as the use of cocaine or other drugs that can cause stroke.
In the Improve It trial, the researchers used, and pardon if I don't pronounce this properly, simvastatin as the statin along with estimimbe. Are there other studies using a different statin in combination with estimimbe?
So that's a really great, as the use of simvastatin, marketed as Zocor, or ezetimibe, marketed as Ezetrol. The simvastatin is a first-generation statin and really hasn't been shown to be as effective in lowering LDL as the two newer versions, which are atorvastatin, which is Lipitor, or Crestor, which is, I'm sorry, I just forgot Crestor's generic name. So we do know that the second generations are more effective at LDL lowering. So whoever sent in that question, very astute of you. There are unfortunately no trials at the present time looking at the common use of ezetimibe with a second generation statin, such as Crestor or Lipitor. And so your question is this a result of having two products on there, or some magic anti-inflammatory effect, or are we just driving the LDLs even lower? The answer is I don't know. For now, I'm comfortable adding ezetimibe to Crestor or Lipitor. I do agree you get better lowering, although it's not an evidence-based approach. We do know that in the Sparkle trial, the mean LDL went to 1.9, and in the Improve It trial, the mean LDL went down to around 1.4. So we have a 0.5 millimole per liter reduction that the simvastatin and ezetimibe were able to give, a lower mean LDL than we saw in the Sparkle trial. So it's not an unreasonable thing to do, because at least in the clinical trial, they seem to do much better. I want to point out, however, that the Improve It trial was only in an acute coronary syndrome population and not in a pure stroke population like we saw in the Sparkle trial.
And should statins be prescribed if LDL is normal?
I think the biggest problem is what's the definition of a normal LDL. So I know many labs have LDLs that range from anywhere from 2.7 to 3.4 or 3.5, what they call normal in their lab. I think normal LDL in the setting of cardiovascular disease is very different. So if you've had a stroke, you should always be less than 2.0. And if you have concomitant coronary artery disease, for now, you should be less than 1.8. And I think as more trials come out with these very potential potent drugs, that these numbers may be dropping in the future.
And what is the current recommendation for statin therapy for hemorrhagic stroke?
So currently there is no recommendation for statin therapy for hemorrhagic stroke. It is not, it's a different disease, and we actually have guidelines clearly stating that it is not indicated for hemorrhagic stroke, for the treatment of hemorrhagic stroke.
And what should you monitor with long-term statin treatment post-stroke, and is dose titration expected for optimal effect?
So I think the statins all require liver function test monitoring. I add in a CK as it can cause myopathy or myositis. So those would be the more important things to monitor. I generally do them twice a year. In terms of the maximal dose, I want to point out one thing. The Sparkle trial randomized people with LDLs of less than 2.0 directly to 80 milligrams of Lipitor. So there was no titration 10, 20, 40, 60, 80, and then you got there. Everyone was started on 80. If you had trouble tolerating the 80, you were allowed to go down to 40. But I do think the maximal benefit is at the highest dose. And that's been shown in a number of cardiac trials, namely the TNT trial, where they showed incremental decrease in event rates the higher statin dose goes. So I personally start all my patients on 80 milligrams, exactly like they did in the Sparkle trial of atorvastatin.
And can you speak a bit more about the IRIS trial and the insulin-resistant test?
Right. So the IRIS trial used a HOMA level. The test is not commercially available anywhere in the world. We do know that people who are insulin resistant are more likely and prone to develop diabetes down the road. So the concept that Larry Brass had was, if we know diabetics are at risk for subsequent macrovascular events, where we've never been great at showing a decrease in events, if we treat diabetes before it becomes truly defined diabetes and is an insulin resistance, can we prevent cardiovascular disease? And I think they did prove that from a proof of concept perception. Unfortunately, they chose a drug that's no longer used and is off the market. I do not know of anybody or anywhere where the HOMA is available right now. You can buy these private test kits in the US, but it's not used by any of my colleagues at the present time, south of the border.
Okay, and then this is taking a different spin on the information that you shared with us today. So from a survivor point of view, can you give an overall view of what you discussed today?
So overall today, in a nutshell, we discussed that patent foramen ovale is a risk factor in the correct population with cardioembolic stroke of unclear source. And when you have a cortically based stroke and you're young, I think PFOs have a strong reason to be closed. Number two is, I think that the lower your LDL, the better is, and I encourage everyone to use maximal statin therapy to decrease their event rates. And individuals with coronary artery disease, I want to remind you that we should be going lower than the standard 2.0 millimole per liter, and that your biggest bang for your buck is always when you can decrease LDLs by around 50%. I think the COMPASS trial gives us a great overview of the more common patient that we're seeing as the polyvascular therapy patient, and that the use of DOACs is really probably on the horizon to treating a whole host of cardiovascular conditions outside of the atrial fibrillation setting. And I think if we can get the bleeding risk under control, will really open up new avenues for us to help conquer heart and stroke disease.
Great, thank you very much. And so that concludes our Q&A and our presentation today. I'd like to again thank our speaker, Dr. Ted Wein. Thank you so much for your time and for delivering such valuable information. Again, please look for the evaluation and complete that. It helps us determine future topics and valuable information for the webinar program that we lead through the Stroke Best Practices. And we will be as well providing the recording again at the end of the month. So again, look for that on the Stroke Best Practices website. And all past recordings are also available on the website. Thank you again for attending, and we hope you enjoyed today's presentation. Have a great afternoon, everyone.
Thank you.